It's Saturday the 11th of May, it's 10:30. It's absolutely glorious here in the centre of Edinburgh. You can see up to Carton Hill in the background there and Waverley Station just here. I've just been teaching with 35 IBD specialist nurses from around the UK, 100 IMID specialty nurses yesterday at the session where I was teaching about pathophysiology of inflammatory bone, joint, bowel and skin disorders, and looking at how we can learn from the immunology of these conditions to direct treatment decisions, particularly where people have more than one affected system. But today, really with the gastro nurses, a very impactful session talking about treatment targets and goals in IBD, thinking about the timing of therapy, tight control and monitoring, and a lot of things that actually increasingly I take for granted a bit actually, but looking at the practice across the country and listening to how people are resourced, some of the structural and infrastructural challenges in terms of providing optimal care, today was a really impactful session. I felt like the teaching today will improve outcomes next week for people with inflammatory bowel disease. And in fact, one of the key things here was looking at how to implement the findings from Profile to newly diagnosed patients with Crohn's disease. So I'll do a deeper dive into Profile, but essentially it tells us that for a newly diagnosed patient with Crohn's disease, the best thing to do is to start effective therapy at diagnosis. And in Profile, it's a biologic with infliximab plus a thiopurine with azathioprine. And at diagnosis actually means within 14 days. So the question then comes, how do you do that if your system currently operates on someone doing the diagnostic colonoscopy, the biopsies getting reported, a GP starting a patient on steroids, and then the next point of care is the patient phoning a helpline 4-6 months down the line to say that they had the steroids, they felt better, but now they've got active Crohn's symptoms again. And the answer here is that actually we need to think about systems of care to improve things. And to me, the profound outcome from Profile is that not so much in Edinburgh where I think we've got good systems or in other major teaching centres, but in many places around the country where everyone is trying to deal with all aspects of gastroenterology with minimal resource. The teachings from Profile have not yet managed to affect practice. So if I'm there at somewhere where my service is not, I think, doing what I want it to do, I can go take the Profile findings and say, look, we have to change practice. If we change practice now for newly diagnosed patients, we will be able then to get more patients into a deep remission at a year. Not only is that better for our patients and how they feel, but that will then improve outcomes. Mucosal healing will decrease the need for steroids, decrease hospitalization, decrease disease progression, decrease surgery, all of which cost the NHS money. And so if money is the issue, we need to front load our service, and there is no better place to front load it than for newly diagnosed patients with Crohn's disease. So whatever the system is, be it pathologists flagging patients with newly diagnosed Crohn's disease on the biopsies, be it doing it at the triage stage, and then facilitating a new IBD diagnosis clinic to get these people onto infliximab and azathioprine, or maybe to adalimumab or ustekinumab monotherapy or another agent straight away. It's not just steroids, it's not thiopurine monotherapy, it's not watch and wait, it's not step up. We know that that results in much worse outcomes in a year, and we know that those outcomes translate to worse outcomes later down the line. And my main message to the nursing teams today was, one, you are doing a fantastic job and utterly pivotal to everything that we are doing in managing our patients. But two, more than that, you really can be the drivers of change. You can be a force for good that takes a well-meaning department goes back to them with new bits of data like the profile study and say, we have to change things. This is how I think we can change things. I can set up and run a new diagnosis clinic and do it on my own if necessary, but much better to do it with a consultant there. And through this, we will educate our patients. We will get our newly diagnosed Crohn's disease patients onto top-down therapy with biologic therapy from diagnosis. That is going to save our patients a year of bad symptoms and steroids and unnecessarily harm. It's going to save them from operations, and it's going to save them from hospitalizations moving forward, and that is going to decrease the burden for our service for inflammatory bowel disease moving forward. That's going to decrease costs, but most importantly, it's going to improve the outcomes for our patients. So those are my key things from here. I will do a deep dive into profile with slides so I can show you through the data in more detail. So keep subscribed to the channel if you haven't already, and look out for maybe the first of what I'm going to call Atomic IBD Deep Dive. But from this Atomic IBD Uncut, from a beautiful sunny Saturday in Edinburgh, I'm going home now to get changed and go for a decent run. Thanks, bye-bye.